All right, so here we're going to be talking about COVID-19. We'll go through a comprehensive review of the virus, diagnostic treatment strategies, and emerging research on new medications. Start off, we'll talk about viral genetics, origin, and evolution. So, the coronavirus is a positive single stranded RNA. There are a number of different coronaviruses, including 6 that infect humans, which include the common cold, MERS, and SARS. The COVID-19 showed 96% similarity to a bat coronavirus, which says that this likely came from bats. And the first cases of this disease were also linked to the Wuhan seafood live animal market. This suggests that there is animal to human spread, followed by human to human transmission, which has now spread globally. The disease also shows 99.9% genetic similarity between samples taken December 2019 and February 2020, which may provide evidence that this virus is mutating more slowly. Here we'll talk about major virulence factors. This is really important to understand because it guides strategies for therapeutic intervention and also the vaccine. So, the major virulence factor for the virus is a spike glycoprotein. This is a protein on the outer surface of the virus with a conserved S2 peptide domain, which facilitates host receptor fusion. Given that the S2 peptide domain is conserved, this is a potential target specifically for vaccines. Other virulence factors, TMPRSS, this is a protease, which is required for priming of the protein of the virus. And then ACE2 is the host receptor that the virus actually attaches to enter into the respiratory cells. Another word about ACE2 is angiotensin converting enzyme. So this is also an enzyme that is targeted by a number of blood pressure medications, and it's involved in the pathway that regulates blood pressure in our bodies. And so there's a lot of research also being done regarding the advantageous or adverse effects of blood pressure medications on the coronavirus and risk of coronavirus. And so that's also really important to understand. Transmission dynamics, based on the evidence so far, we still don't really know how coronavirus is spread from human to human. We know that it's facilitated through close contact with individuals, including households, hospitals, nursing homes, and prisons. The evidence at this point, which I've linked some articles below, is pointing towards primary droplet transmission. So this is when human respiratory secretions from a cough or a sneeze get into the eyes, nose, and mouth of somebody who's very nearby, within 6 feet of an infected individual. Coronavirus can also spread through fomites. Fomites are inanimate objects or surfaces that the virus can stay on for a number of hours for a certain period of time and facilitates transmission between an infected individual and an uninfected individual. So fomites could include surfaces, and it's been found that coronavirus can last for up to 3 days on plastic, 2 days on stainless steel, 1 day on cardboard, and less than 4 hours on copper. However, the coronavirus has an exponential decrease in viral infectivity and viral titers. Even though it lasts this number of days in time, the actual virulence of the virus goes down over time. It's also found that ethanol solutions greater than 78% and 5% bleach is effective in neutralizing or killing the virus. There's also some evidence for airborne transmission. This isn't a primary way that the virus spreads, but specifically in invasive airway procedures such as bronchoscopies and mechanical ventilation. These invasive airway procedures can aerosolize particles, and coronavirus has been shown to last approximately 3 hours in aerosols. And so if you're doing an invasive airway procedure, that would warrant the use of an N95 respirator, but in routine patient care, this isn't a primary mode of transmission, and the recommendation now is for N95s, negative pressure rooms during these invasive airway procedures or for people who are mechanically ventilated. There's also some evidence for fecal shedding in a small amount of cases, as well as blood positivity. In terms of surface stability, the mean incubation time is 5.2 days. That is the amount of time between when someone gets infected and when they start to show symptoms. The maximum incubation time, the 95% confidence interval, was at 12.5 days. So the time when someone gets infected to the time that they show symptoms can be very variable for up to 12 to 14 days. The doubling time, that is also variable based on where you're looking at, but this is based on the data from China specifically, which showed doubling time of 7.4 days. This can be related to how well you're practicing social distancing, and a number of other epidemiologic factors of the society that it's spreading in. And so it's been found that doubling time is actually varied based on where in the world you're looking at. And each infected individual spreads a disease to approximately 2.2 other people. But of course, that's also variable. There are a lot of risk factors which are associated with increased risk for adverse outcomes with coronavirus. Those risk factors include age and the presence of other comorbidities. So an age greater than 60 confers an increased risk for death and severe disease. And the case fatality rate rose to 14.8% for people who are over age 80 from a baseline of 2.4% case fatality rate. Presence of comorbidities like cardiovascular disease, hypertension, diabetes also increase your risk for death from coronavirus. Cardiovascular disease had a case fatality rate of 10.5%. People with hypertension had a case fatality rate of 6%, and diabetes had conferred a case fatality rate of 7.3%. There's also a lot of ongoing data, arguments, and research about the adverse or beneficial effects of ACE inhibitors and ARBs in coronavirus. As we mentioned before, ACE inhibitors block the ACE enzyme, and so it's blocking the receptor that the virus is actually using to get into the respiratory epithelium. However, ACE inhibitors and ARBs also upregulate the ACE enzyme. And so there is some debate about whether having an ACE inhibitor on board can increase your risk for having a bad coronavirus. Right now, because the evidence is still conflicting, the ACC guidelines recommend continuation of RAS until evidence-based measures are in place, or until we have more data. In terms of symptoms for coronavirus, we have data regarding the case severity. So about 80% of patients will have a very mild upper respiratory illness, including fever, cough, sore throat, headache, and general malaise. 13.8% will have severe pneumonia requiring oxygen therapy, and 4.7% will have critical acute respiratory distress syndrome or sepsis requiring ICU care and mechanical ventilation. Of course, this data also varies based on where you're looking at. There's preliminary evidence, for example, in Italy, that shows that the number of critical cases is higher. And so we're still awaiting the evidence and the data for other locations. This is mostly based on the data coming out of China. Regarding symptoms, we have 88.7% of patients that eventually will develop fever. So it was found that a smaller number of patients actually presented with fever when they first arrived to the hospital, but 80.7% eventually developed fever. 67.8% had cough, 5% nausea and vomiting, and 3.8% diarrhea. In terms of diagnostic strategies, we have laboratory-based, which is the gold standard. RT-PCR, polymerase chain reaction, helps us to detect the presence of virus in certain secretions. So we have nasopharyngeal, oropharyngeal from the nose or the mouth swabs, We have bronchoalveolar lavage, which is basically when they take a sample of fluid from the very lower airway or the bronchi. We can also have sputum samples or other aspirates. There was a study that found that the highest number of positive specimens were in bronchoalveolar lavage, followed by sputum, followed by nasal at 63%, and oral swabs at 32%. And then fecal was positive in 29% of patients. There are no published sensitivities or specificities for RT-PCR, but in general, positive test confirms you have coronavirus. Negative test does not necessarily rule out that you have it in the proper clinical scenario. Regarding imaging, there's a lot of debate about the role of imaging in actually diagnosing coronavirus, but 82.1% of non-severe cases had abnormal CT findings, and 97% of severe cases had abnormal CT findings. The most common CT findings were bilateral peripheral and basilar ground glass opacities or patchy hazy opacities. This is very non-specific. A lot of viruses can have this sort of presentation on CT scan. So as you see the specificity, it was only 25% for CT scans. The sensitivity was 97%. Because the CT is non-specific, it's not recommended that you use CT for diagnosis. Other issues with CT that kind of pushed the CDC, the American College of Radiology, away from recommending CT is the fact that you still need the laboratory confirmation to decide that this person has coronavirus. The imaging itself is not sufficient. And then there's also this additional issue of machine contamination, because when a patient goes for CT, every patient goes for CT has to have the machine decontaminated afterwards, and increases the risk of spread of disease in the healthcare setting and also to health providers and the techs that are administering CTs. In terms of patient management, we're going through non-treatment management strategies. Here we have strategies for personal protective equipment based on the evidence we have thus far for mechanisms of disease spread. So the recommendation now is a face mask, gown, gloves, and eye protection, with N95s reserved for aerosol generating procedures. And there are also guidelines in place for crisis scenarios, given that we're already in an N95 shortage, we're already in mask and gown and glove shortages. There's guidelines for how to optimize reuse of this personal protective equipment if it ever comes to that level. So in terms of management, for patients who have known exposures, the recommendations for home quarantine for 14 days to make sure that they don't show symptoms or until the PCR tests come back negative. If somebody has a mild case or mild disease, the recommendation is home isolation with or without PCR testing. If anyone's showing symptoms, the recommendation is that you home isolate. Manage your symptoms and then counsel for severe symptoms that will warrant hospitalization, as we had mentioned before. The recommendations for when to stop isolation are when you get 2 consecutive negative PCR nasopharyngeal swabs 24 hours apart, or you have had 72 hours since the resolution of your fever and symptom improvement, as well as 7 days since the onset of your symptoms. In terms of management for severe disease, we look at oxygen therapy with a goal oxygen saturation of 94%. We also use ventilation with high PEEP if this doesn't work. And then if someone's presenting with sepsis or septic shock, we would administer the sepsis protocol. Lastly, we'll talk about experimental treatments. These include antivirals, chloroquine, and adjunctive therapies, namely immunosuppressants, immunomodulators, as well as other theoretical treatments, such as inhibitors of the protease and the ACE2 receptor. I'll start off by saying that there's no treatment that has been proven to be efficacious in treating coronavirus. This evidence is a lot based on prior studies in MERS, Middle East Respiratory Syndrome, and the Ebola, but there isn't actually data showing that any of these treatments would be efficacious, but they're often administered on a compassionate use basis, given that we really have nothing to provide to patients who are in critical condition at this point in time. So with that disclaimer, we'll start off by going through some of the evidence for some of these treatments. We have remdesivir. Remdesivir is an adenosine analog that incorporates into viral RNA chains and results in premature termination of the viral RNA. So remdesivir, according to the World Health Organization, is the most promising medication for treating coronavirus at this point. It's previously shown efficacy against MERS-CoV and Ebola in both animal and human data, which is linked below. And then the NIH is also administering a trial for remdesivir, 200 milligrams IV, followed by 100 milligrams for 10 days in patients. We also have lopinavir ritonavir, which is a protease inhibitor, which is used in HIV and hepatitis C infections, preventing cleavage of the viral pre-protein into active products. The World Health Organization had previously recommended this as a second-line agent against coronavirus, but a recent randomized controlled trial came out in the New England Journal of Medicine. The link for that is here below in number 7, which showed that in 199 adults with severe COVID infection, that this medication did not reduce viral load and only reduced length of symptoms by 1 day. So preliminary data is leaning towards lack of efficacy, but we need to have stronger evidence moving forward. Then we have chloroquine. So chloroquine is another really promising treatment for coronavirus with 3 proposed mechanisms. The first is that it inhibits fusion through increased endosomal pH. Second, it interferes with the glycosylation of SARS-CoV receptors. And thirdly, it results in host immunomodulation. So chloroquine is a very commonly used medication for malaria treatment. It has a very low cost. It's globally available in nearly every country around the world. It has very few side effects, and it has very good oral bioavailability. We have 70 years of data to show that this is a very safe and good drug for patients. But we need to establish that this has efficacy in treating coronavirus, and that data just isn't there yet. In terms of adjunctive treatments, we can think of steroids. So steroids are mainly used to reduce the host inflammatory response, so our own body's response to the infection. You know, steroids have many side effects, and they also blunt the host response to the viral replication and can increase viral loads. So this is typically reserved for very severe cases in the ICU setting. Interferons, there have been studies on other coronavirus infections, namely MERS, with alpha and beta interferons. Alpha interferon showed no efficacy in prior coronavirus data. Beta interferons showed efficacy in MERS in combination with other antivirals. So it was effective when used as an adjunctive treatment along with other antiviral medications. There's also been data on antibodies. So it's been shown that patient serum neutralizes virus in bronchoalveolar lavage fluid. So the patient serum is the portion of the blood where antibodies are present, and this is able to neutralize the virus. It's also shown safety and intolerance of up to 50 milligrams per kilogram in MERS patients. Efficacy is indeterminate for SARS-CoV-2, or the current coronavirus infection. Lastly, I'll go through some ongoing research. There are some other proposed therapies where no data at all really exists, but these are potential avenues for future research. Those include TMPRSS2, the serum protease inhibitors, ACE2 receptor blockers, or recombinant soluble ACE2 receptors. And then there's also a question of whether ACE inhibitors might have a therapeutic or harmful effect on coronavirus infections. That data is still up for debate, and there isn't strong evidence in either direction. And then there's also vaccine development against the spike glycoprotein specifically. So that's a summary of all of the data we have thus far. or all of the important points in the data we have thus far. Hopefully, as we learn how this virus works and learn how to control it, then the number of new cases, the number of cases worldwide is going to go down, and this epidemic will be under control.